Here we have a 72-year-old man with asymptomatic severe left carotid stenosis. He has a history of anterior myocardial infarction with an ejection fraction of 45%. He's hypertensive, hyperlipidemic, and a former smoker. The patient chose the stenting approach.
We see here an atheromatous calcified plaque in the left internal carotid. With the Doppler color, we directly see an aliasing. That means that there is a severe stenosis, and when we put the pulse Doppler, it confirms that the stenosis is approximately under 80% because of the peak of systolic velocity at about 3.5 meters per second. Now, seeing the transcranial Doppler, at the side of the stenosis, the flow is totally normal, so systolo-diastolic with a peak of systolic velocity at 63 centimeters per second. And on the right side, you see that the flow is strictly normal after compression, confirm that the polygon of Willis is functional and allows to use an anti-embolic proximal occlusion system for this procedure.
We can see that this patient has a type 3 aortic arch, a severe lesion on the origin of the internal carotid artery, followed by a significant tortuosity. Here we have the intracranial view. To access the left common carotid in a single step, I choose to use the SAD left 1 catheter. Through the 6 French SAD catheter, we can easily, under close control, place the supracore extra stiff wire into the external carotid artery. I prefer to use this approach instead of a 5 French Siemens catheter with a roadmap, because it is not always that easy to advance the extra stiff wire into the external carotid artery, especially when the carotid bifurcation is narrow, and keeping in mind that the extra stiff wire can straighten the common carotid and make the roadmap fixed image less precise. The extra stiff wire is in place. The 6 French SAD catheter is withdrawn.
So here in this patient, we are going to use a proximal occlusion protection system with MoMA protection device. We start by preparing the external carotid balloon for the external carotid artery. We'll aspirate for about 10 seconds. We do the same thing on the balloon of the common carotid. We aspirate and we hold for 10 seconds to ensure that there's no bubble. Here we have the mandrel. Putting the mandrel into the catheter. And now we start to backload the MoMA catheter on the extra stiff wire.
And the 9 French MoMA is advanced into the external common carotid. We check the position, inflation of the external carotid artery balloon, preparing the 0014 wire and the predilatation balloon into the MoMA catheter, inflation of the common carotid balloon, predilatation, preparing the precise stent 8/40 millimeter,
chasing the bubbles. Okay.
Placing the precise stent, post-dilatation.
And before deflating the balloons, we aspirate 60 cc of blood, and we filter the last syringe to see if there's any debris in it. Then we deflate the balloons.
Checking the result. Here we see a very nice result. Withdrawing the MoMA catheter.
So after the procedure, we see the stents into the internal left carotid artery. And with Doppler pulse, you see that the flow is strictly normal, confirm the excellent result after procedure.